So I just spent the past 5 minutes trying to look for my stylus for my graphics tablet, and I don't have power, so this PC better not test me. Even though I'm God's favorite son, it better not test me because I'm not ready to do this video more than once. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at arterial blood gases. This is just going to be a lecture based on interpretation, and it's just going to be really the bare basics that you need to learn in order to start being able to understand about arterial blood gases, which I will abbreviate as ABGs. I decided to do this method of teaching in terms of using a blackboard because a lot of you people found it as a very interactive way to learn, so as opposed to just having a lot of slides there. Of course, there are some people who do complain that I talk very fast, so I'll try to be as slow as possible so that everyone can understand what is going on. So now, remember that in the system you have predominantly two main systems that are responsible for control of acid-base. We have what is known as the renal system, and this renal system is going to be consisting of the kidneys. So I want you to keep in mind that these kidneys are the ones that are going to be responsible for pretty much excretion of certain electrolytes, reabsorption of certain electrolytes, excretion of certain waste materials in the body. Another system that is very responsible for acid-base balance is, of course, the respiratory system, the lungs. I will attempt to draw the lungs here. So you have the lungs that are responsible because they're going to be dealing with pretty much the excretion of carbon dioxide, because carbon dioxide is very important, especially in acid-base balance. So you have our carbon dioxide there that's going to be dealt with by the respiratory system. Now, basic physiology. So remember that the pH of the body is going to be regulated roughly between 7.35, so 7.35 to about 7.45. Now, the ideal pH that is necessary for most of these enzyme reactions to take place is actually 7.40. So keep this range in mind, keep the 7.35 in mind, keep the 7.45 in mind, and the ideal pH ideally should be 7.4. Now, there are some times where you could have problems in the metabolic system that could arise where you're now producing excess acids. You could have problems in the respiratory system where someone is hyperventilating and pushing out a lot of this carbon dioxide, or someone is hypoventilating where they're retaining this carbon dioxide, or indeed this person could be losing a lot of the bicarbonate in their urine. They could be losing a lot of acid, which are going to be representing as hydrogen ions in their urine. So whenever you're saying that something has to do with acid, what we're simply talking about is either hydrogen ions or mainly you're going to be your bicarbonate. So your bicarbonate is going to be abbreviated like that. In the respiratory system is something to do with carbon dioxide. I want you to keep in mind this because this is like literally the basic physiology. So anything that is causing a change in the pH that is coming from outside the respiratory system or coming from the metabolic system is going to give rise to these metabolic acid-base imbalances. And these metabolic acid-base imbalances are going to be compensated for by the respiratory system. For example, if someone has a diabetic ketoacidosis, remember that because of the pathophysiology that is going on and accumulation of these keto acids that are a product of beta oxidation, this will mean that these keto acids will increase the acid concentration of the bloodstream. So it means the pH is going to drop. So what is the patient going to do? There are going to be certain sensors in the body that are going to sense that this pH has dropped. So it means that there's going to be some compensation. You're going to see some effects in the respiratory system in order to compensate for this extra acid that you're accumulating because of the metabolic system. And the reverse is true. So you can either have some compensation happening in the renal system because someone is hypoventilating or hyperventilating. And remember that the compensation that is often happening in the respiratory system is going to be very quickly. So it can happen very quickly. While it's the compensation that is happening in the renal system usually takes a few hours or sometimes even a day or so, more than a day, for it to actually kick in. So these compensatory mechanisms are quite different. And whenever you have problems in the respiratory system causing acid-base imbalance, these are going to be compensated by the metabolic system, predominantly the kidneys. If you have the problem in the metabolic system, this is going to be compensated for by the respiratory system. So in essence, the main acid-base imbalances, remember that our usual pH, I don't know why it keeps erasing or keeps getting rid of my pen. So remember that the main acid-base imbalance that you may have, we have a pH of 7.35 to about 7.45. Now, if someone has a pH that is less than 7.35, if someone has a pH that is less than 7.35, we're going to refer to that as acidosis. So this is going to be referred to as acidosis. If someone has a pH that is greater than 7.45, meaning that pH is increasing beyond this normal range of 7.35 to 7.45, we're going to refer to that as alkalosis. Okay, so we have alkalosis. I don't know how I spelled that wrong. Alkalosis. So we have acidosis, where the pH is dropping less than 7.35. We have alkalosis, where the pH is greater than 7.45. Each of these things could be caused by either metabolic problems or respiratory problems. So you could either have a metabolic acidosis. One example that I have given you is if someone is producing acids in the body. For example, in patients that have DKA. So because they are producing these keto acids and they're accumulating in the blood, you have this acidosis that is going on because of metabolic processes that are producing these hydrogen ions, metabolic processes that are producing these keto acids, and also these metabolic processes that could also be even producing lactic acid. So we can even see this in patients that have septic shock, for example, those that have infections. But I'll put a question mark on this because in terms of septic shock, it can also cause some respiratory issues. Then on the other end of the spectrum, we have what is known as the respiratory acidosis. Remember that here, I say this has to do with the respiratory rate and it has to do with carbon dioxide. So anything that is going to be causing the patient to hyperventilation is going to result, or anything that is going to trap air inside their system is going to result in this person developing a respiratory acidosis. For example, if someone has a COPD and of course they are trapping this air in the system, and because of this COPD that is often trapping air into the system, this COPD is going to lead to this retention of this carbon dioxide. And remember that carbon dioxide can undergo certain reactions. So I'll put a side note here, and so that you can write the reactions that carbon dioxide actually undergoes. So remember that carbon dioxide is going to react with water, and this is going to be a reversible reaction in the presence of an enzyme that's known as carbonic anhydrase, and this is going to eventually form our the carbonic acid. This carbonic acid can also further dissociate into our hydrogen ions plus our bicarbonate ions. Now, it is these hydrogen ions here, because you have increasing the concentration of carbon dioxide, so you have a lot of these raw materials on this side of the reaction, so all the reactions will be pushed forward. So you're going to be forming a lot of carbonic acid, it's going to be breaking down into hydrogen ions, and this is what's going to be causing the respiratory acidosis. So you could see this in patients that are hyperventilating, for example, in those patients that have COPDs. Then in terms of alkalosis, it could also be arising as a result of metabolic problems. So it could be metabolic alkalosis. For example, if someone is losing, I don't know why I keep spelling alkalosis wrong. For example, if someone is losing acid in their system, they are, for example, vomiting. because remember they're losing that acid that's present, they're losing some of these electrolytes, they're vomiting, they'll go into a metabolic acidosis. So usually GIT related issues, vomiting and all those things are going to be causing a metabolic alkalosis. Then it may sometimes be a respiratory alkalosis. So now, in terms of this respiratory alkalosis, remember we're coming back to these reactions. Now, if you have someone hyperventilating, so someone who is hyperventilating, they have maybe, like I told you, they have an infection, a sepsis that's causing their respiratory rate to be quite high. So sometimes that hyperventilation will cause this carbon dioxide to be washed out on this reaction here, this carbon dioxide. And once this carbon dioxide has been washed out, it means all these reactions will reverse. Instead of you forming these hydrogen ions, they'll combine with the bicarbonate to form the carbonic acid. Carbonic acid will break down to the water as well as the carbon dioxide, which keeps being pushed out because this person is hyperventilating. So that's how a patient is going to be developing this respiratory alkalosis. So the four main acid-base imbalances I want you to keep in mind, bare basics, is pretty much our metabolic acidosis, our respiratory acidosis, our metabolic alkalosis, and our respiratory alkalosis. Now, if you have problems in the metabolic system, you expect to have some changes in the respiratory system. So if you have a metabolic acidosis, you would expect changes that are going to cause a respiratory system to push out some of this carbon dioxide, because the assumption is that if you are acidic, one way to get rid of that acid is to push out the carbon dioxide so you can make your blood alkalinic by respiratory processes. So you would expect the compensation to happen with the respiratory system. Same thing if it's happening in the respiratory system. For example, someone has a respiratory acidosis, it means that the kidneys will try and excrete this bicarbonate in it will try and retain the bicarbonate so that you can create a metabolic alkalosis to buffer this acidosis that you have caused in the respiratory system. I really hope that makes a lot of sense. So this is like the bare basics that you need to understand when interpreting your arterial blood gases. So the very first step in interpretation of these arterial blood gases is, of course, analysis of the pH. I'm going to show you 6 steps that you're going to be using to analyze ABGs and for you to arrive at a diagnosis on what your ABGs are telling you. And the first step that's going to be there is, of course, analysis of the pH, which I've already talked about a bit in detail. So remember that our normal pH, this should be in white because we don't want a red pen. People complained about the red pen as in they weren't able to see very well. So our first step is, of course, analyzing our pH. Remember that our pH is going to be about 7.35 to about 7.45. And our optimum pH is going to be 7.4. That's our ideal pH is supposed to be kept at 7.4. But remember that the body can also tolerate these ranges of pH between 7.35 to 7.45. Now, there are some times where you're going to get an ABG and, for example, your pH looks a little bit normal. For example, your pH is going to be 7.37. So suppose you get an ABG and your pH is 7.37. Again, remember, if there's a underlying problem in this person, there's some compensation that's going to be there. And remember that the whole goal of this compensation is to take the pH and bring it as close as possible to the normal. But remember that we cannot really reach the normal. The compensatory mechanisms cannot really compensate for you to actually normalize your pH unless if that underlying problem has been dealt with. But of course, it will get your pH closer to the normal. So if it's in the normal range of 7.35 to 7.45, but it's not 7.40, then you should think that there is some compensation, and most likely that compensation is a fully compensated type of situation. It's not a partial compensation, because if it's a partial compensation, you would expect certain changes, but your pH will not be close to the normal. But if it's very close to the normal, then it's most likely that this is a fully compensated type of thing. But if you now get a normal pH like this, now you should think, on which side does this lie on? So if it's less than 7.45, 7.40, it means that this is going to be slightly acidic. So it's on the acidic side. So whatever is happening in this patient that has a 7.3 pH, it means that there's some compensation that is happening to make this pH 7.3. This person has compensated. So like I already said, the first thing that you're going to determine is whether this person has an underlying acidosis or whether this person has an underlying alkalosis. So step one, of course, if the pH is less than 7.35, then we're going to say that this person here has an acidosis. Then if the pH is greater than 7.45, we're going to say that this person has an alkalosis. So that's the first step. Just look at the pH, determine whether the pH is an acidosis, determine whether the pH is an alkalosis. Because remember that there will be some compensation that is there to take the pH closer to the normal. The ideal or the optimum pH that you're going to be looking at is 7.40. The second step that is there now is you're going to analyze the partial pressure of carbon dioxide. Now remember that the partial pressure of carbon dioxide is going to be often measured by your arterial blood gases, and the normal partial pressure of arterial partial pressure of carbon dioxide is almost close. You can just look at the last two digits of the blood pH. So remember the blood pH, we said it's a range between 7.35 to 7.45. The last two digits after the decimal point is 35, 45. So the normal pH of, or rather, the normal partial pressure of the carbon dioxide is going to be 35 millimeters of mercury to about 45 millimeters of mercury. Very important to actually realize this, because remember that changes in the respiratory system are going to cause changes in the partial pressure of carbon dioxide. So what do I mean? So if your partial pressure of carbon dioxide is less than 35 millimeters of mercury, then we'll say that this person here has pushed out a lot of carbon dioxide. And remember, carbon dioxide is equivalent, or I can say almost equivalent, to a hydrogen ion. So it has pushed out this hydrogen ion. So it means that this is a person that is hyperventilating. So this is a person that is hyperventilating. So this will mean that this is a person that ideally has an alkalosis, because they are blowing out this carbon dioxide. This is ideally a person that has an alkalosis. They're blowing out the carbon dioxide. The partial pressure has been reduced. Now, the next thing that I want you to keep in mind is if the partial pressure of carbon dioxide now is above 45 millimeters of mercury. Here now this person is retaining carbon dioxide. And remember, once carbon dioxide has been retained, this is going to mean that you're going to be having a lot of hydrogen ions in your system. So this would be in the background of a patient that is hypoventilating. So this would be in the background of a patient that is hypoventilating. So this is going to signify someone who's having an acidosis, because they're retaining this, they're retaining the carbon dioxide, so their partial pressures are going high. So that's the next step. So remember, step one, you first analyze the pH to see whether the pH is acidic or whether the pH is alkalinic. The next thing is to analyze the partial pressure of carbon dioxide to determine whether it is alkalosis or whether it is acidosis, then, or whether it's normal between 35 to 45. I'll explain what it means now and how you're going to tie these two together so that you can determine whether this person has a respiratory acidosis, a respiratory alkalosis, or a metabolic acidosis or metabolic alkalosis. So that's our step two. Then we come now to our step three. We now come and analyze the bicarbonate. So remember that this bicarbonate is going to be produced by the kidneys, and it's going to be a component of the blood gases. So now our normal levels of our bicarbonate is going to be about 22 to about 26 milliequivalents per liter. So your bicarbonate must be kept within this normal range. our 22 to 26. So if someone has a concentration less than 22, then we say that this person has an acidosis. Because remember, bicarbonate is alkalinic. So if you're losing it in the urine, it means that you have less bicarbonate in your blood. It means that your blood is going to be acidotic because you have lost the thing that is making your blood alkalinic. So this is going to be representing acidosis. Then if your bicarb is going to be greater than 26 milliequivalents per liter, then this is going to be now pointing towards our alkalosis because you have retained a lot of this bicarbonate, which is giving you the alkalinic nature of your blood. Okay, because remember, the hydrogen ions will give you the acidic nature, the bicarbonate is going to be giving you the alkalinic nature. But just like with the pH, I'll tell you now how you're going to, rather, like partial pressure of carbon dioxide, I'll tell you how you're going to be linking the partial pressure of carbon dioxide to the pH, as well as linking the bicarbonate to the pH in the next slide. So our step 3 is to analyze the bicarbonate that is given, whether it's acidic, whether it's alkalinic, and then we move on now to step 4. So our step 4 is now we're going to be matching either the partial pressure of carbon dioxide to the pH or the partial pressure of bicarbonate to the pH, so that we can now determine whether the primary acid-base balance or acid-base imbalance is of respiratory nature or the primary acid-base imbalance is of metabolic nature. So what do I mean by this? So for example, I'll give you some examples that you may have. You may come across patients that of course have a low pH here, which is indicative of acidosis. Then at the same time, you're going to be having a patient that has a partial pressure of carbon dioxide here that is high. So that is greater than 45 millimeters of mercury. Remember, if the partial pressure of carbon dioxide is high, greater than 45 millimeters of mercury, remember that here it means that you're hypoventilating. You are retaining carbon dioxide. So this is going to also be causing an acidosis. So if you get these two matching, the low partial pressure of the pH going in the same direction of causing acidosis, and you get the partial pressure of carbon dioxide going towards acidosis, so it means this scenario that you have created, this is a patient that has respiratory, because remember, carbon dioxide is usually going to be affecting the respiratory acidosis or alkalosis. So this patient here is going to be having a respiratory acidosis. I'll repeat. If you have a patient that has a low pH, you have assessed the pH and you find out that the pH is low. So that's pointing you towards an acidosis. You would assume that, remember that concept I told you that problems in the metabolic system are going to be affecting the respiratory system, and problems in the respiratory system affect the metabolic system. But you now look at the partial pressure of carbon dioxide. You realize that it's going in the same direction as the pH. It's making the pH acidic. So it means this was most likely the primary disorder that is causing the pH to be acidic, because if it was a compensation, you would expect this compensation either to be normal if it is partially compensated, or you'd expect the partial pressure to be low because you're washing out that carbon dioxide so that you can create an alkalinic nature to buffer the acidity that has been created. But in this case, that's not the case. The opposite is happening. You have a low pH, which is indicative of acidosis. You have a very high partial pressure of carbon dioxide, which is indicative also of acidosis. So these are the same thing. So it means that most likely this person has a respiratory disorder, because carbon dioxide has to do with respiratory issues. So it means that you would expect the compensation of this patient to happen in the renal system, in the bicarb. But of course, I'll come back to that in terms of step 5. For now, I just want you to look at step 4. And see what's happening in step 4. So that's our first scenario. This is our first scenario here, scenario number 1. Then our second scenario here that we can possibly have is, now let's say if we have a pH that is high. Remember, if your pH is high, greater than 7.45, this is going to be pointing towards an alkalosis. Okay, so this is going to be pointing towards an alkalosis. Then if you check the partial pressure of carbon dioxide, remember that if this partial pressure of carbon dioxide is now low, less than 35, millimeters of mercury, it is low. Remember that this is a person who's hyperventilating. They are pushing out a lot of carbon dioxide. So this is a person that now creates an alkalosis. So you know that the alkalosis that is causing this pH to be high is being created by this carbon dioxide that is being pushed out very quickly. So this is a patient that is having a respiratory problem, because both the partial pressure of carbon dioxide is matching the pH of the blood. So this is a patient that is having a respiratory alkalosis. So notice the difference between our respiratory acidosis and respiratory alkalosis. Again, you would want to see compensation happening in the renal system, and this compensation is going to be taking quite some time. Then our scenario number 3 here is, now suppose if the pH is low, so pH is low. Again, this is indicating an acidosis. The pH is low, is going to be indicating an acidosis. Then after this, we get the bicarb as well. We look at the bicarb. The bicarb is low, so meaning it's less than 22. So the bicarb is low, so this is going to be meaning that there is an acidosis in this patient. Then we also go in further and we look at now the partial pressure of carbon dioxide. We realize that the partial pressure of carbon dioxide is normal. So most likely there may not be any compensation that is happening here as of yet. Now, this scenario that we've given here, remember the bicarbonate and the pH are going in the same direction. Both of them are acidosis. Remember, the bicarb is a product of metabolic reactions. So this patient here is having our metabolic acidosis. So this is a patient that's going to be having our metabolic acidosis. So this is the bracket of the patient that we're going to be having. Then our fourth and our last scenario in terms of matching our partial pressure of carbon dioxide as well as the bicarbonate to the pH. Now suppose we have a pH now that is high, and remember that this pH that is high is going to be signifying an alkalosis. So this pH that is high is going to be signifying an alkalosis. So remember, again, if you have a lot of bicarbonate that is accumulating, this should not normally make sense, greater than 26. This should not normally make sense, because if the pH is alkalotic, you would expect to lose a lot of bicarbonate in the urine. You would expect the bicarbonate to be low. But in this case, you look at the bicarbonate and the bicarbonate is high. So this is also pointing towards an alkalosis. So it means that this is most likely coming from a metabolic problem. And then again, you check your partial pressure of carbon dioxide. It may be normal in this case. Then this whole bracket that I've described here, this is a patient that has a metabolic alkalosis. So these are the four basic things of how you're going to now determine the primary disorder, whether it's a respiratory nature and whether it's of metabolic nature. Of course, it will fit with the clinical picture that you have of that particular patient. So that's how now we come to step 4. We're building on the concepts. Then now we're going to be coming to step 5, where now we determine whether there's compensation or there's no compensation. Remember, if it is a person that is having problems in the respiratory system, you would expect them to have compensation in the metabolic system. So for example, if you actually look at this patient and you say this patient here, so when the carbon dioxide here accumulates in their system, so you have a lot of carbon dioxide accumulating into the system here, so the partial pressure of carbon dioxide is going to be greater than 45 millimeters of mercury, and you had this patient having the pH that is very low, so a pH that is less than 7.35, we say that both these scenarios are causing acidosis. And the type of acidosis that is being created here is the respiratory acidosis. Now, in this bracket of patients that is having respiratory acidosis, we expect compensation to happen inside the renal system. And you should think this through and it should make sense. If you're having an acidosis, what would you rather do? Lose the bicarbonate or regain the bicarbonate? If you have said regain the bicarbonate, you're right. So you'd expect that this person who is having the respiratory acidosis, you would expect them now to regain the bicarbonate. So you'd expect them to be having high levels of bicarbonate in their system. So these high levels of bicarbonate, they're going to be having some alkalosis, and this alkalosis is meant now to compensate. This is meant now for the compensation to happen. But remember, as long as the pH is not within the normal range, it's not above 7.35, even in the compensation, then you know that this thing is not fully compensated. So for example, if this person here had a pH of 7.25, I'll give you practical examples then so that you can understand this. 7.25, our partial pressure of carbon dioxide was above 45, and our bicarb is quite high. So it means that this person is partially compensated because the pH is still very low for this patient. But if the pH of this patient, for example, was about 7.37, and they had a very high bicarbonate, then this 7.37 is within that normal range, but it's on the left side of 7.4. So it means it's slightly still acidic. So it means that there is full compensation that has happened. And of course, the opposite is true. So I've discussed what is happening in terms of a primary respiratory pathology. The compensation is happening in the metabolic system. What about the opposite? So what if now we have someone that primarily has a high bicarbonate, or rather, let me not use a high bicarbonate, someone that has predominantly a low bicarbonate. So we know that that is an acidosis. And we also check the pH, and we see that the pH here is also low. So this is also an acidosis. So in this bracket of patient, this is a patient now that has a metabolic acidosis. A metabolic acidosis. For example, a patient that is having a DKA. So now, this person who has a metabolic acidosis here, if there is compensation that is happening, remember the compensation is meant to happen in the respiratory system. So it means that to get rid of that acid, in the respiratory system, acid is equals to carbon dioxide. So this person must hyperventilate. Once this person is hyperventilating, what do you expect to see in the partial pressure of carbon dioxide? You expect the partial pressure of carbon dioxide to begin to fall. So you'd expect the compensation to be a fall in the partial pressure of carbon dioxide less than 35 millimeters of mercury. Then you'll say that this has some compensation going on. And remember that if your pH now is, for example, again, 7.3 or rather 7.47, then the compensation is partial. But if it's, or rather, full, if it's within that range of 7.35 to 7.45, if it's not 7.4. If it's still very low, for example, if it's a 6 and the partial pressure of carbon dioxide is less than 35, then this is a partially compensated type of acid-base imbalance. I hope you actually understand this bit. If you don't understand, I think you understand when I give you the examples, and then if you still don't understand, you can actually rewind and then watch the segment again. The last and the final step is to look at the partial pressure of oxygen. This is supposed to be the partial pressure of oxygen, not carbon dioxide. This was a typo here. So you're going to be looking at the partial pressure of oxygen. So forget about the C here. It's supposed to be partial pressure of oxygen. So you look at the partial pressure of oxygen. You also look at the SpO2. So remember that your SpO2 at least must be above 92%. And of course, your partial pressure of oxygen must be at least greater than 80 millimeters of mercury, so about 80 to 100 millimeters of mercury, such that if a patient has any of these two values that is less than 92% and a partial pressure that is less than 80%, then we're going to be saying that this person has hypoxia or hypoxemia. Okay, so it means that whatever acid-base imbalance that they're having, in addition to that, they have some hypoxemia. Then sometimes if you're giving supplemental oxygen, you may realize that the partial pressure of oxygen may sometimes even be much greater than 100 millimeters of mercury. So now, let's come to the examples and see exactly how we're going to determine this. So I'll first give you the example, and then I'll give you time to pause the video so that you can actually work them out, and then I'll work you through the example. So example 1, we have a pH of 7.28. We have a partial pressure of carbon dioxide that is 56 millimeters of mercury. We have a bicarb that is 25 milliequivalents per liter, and we have an oxygen saturation that is 89%. Okay, Now work out the diagnosis, or work out the acid-base status of this particular patient. So you may pause the video right now. Okay, so now let's work through this example. So remember, from our step 1, we first want to look at our pH. We determine, is the pH acidic or it is alkalinic? Remember, our normal range of our pH is 7.35 to 7.45. So this one here, 7.28, is much less than this range. So it means that this person here has an acidosis. This person here has an acidosis. So that's step 1. We have an acidosis primarily. So we look at the partial pressure of carbon dioxide. Remember, here is going to be about 35 to about 45 millimeters of mercury. This is much greater than this. So it means this person is retaining carbon dioxide. They are retaining carbon dioxide. They are making a lot of these hydrogen ions. So it means that this person primarily has an acidosis. So this person here has an acidosis. So you see, acidosis here, because it's happening with the partial pressure of carbon dioxide, most likely it's of a respiratory nature. So this person here most likely has a respiratory acidosis. Okay, now let us determine to see whether there is compensation or there isn't compensation. Our bicarb is 25. So remember that our normal bicarb is going to be 22 to about 26 milliequivalents, but this here is 25, so it's within the normal range. So this is normal. You would expect that if there's an acidosis, you expect our bicarb here to be increased, to be higher than 26, but it's not. So most likely this person has not compensated, because remember that compensation in the metabolic system takes a very long time. So this one here is an uncompensated type of thing. And if we look at the saturations there, 89%, most likely even the partial pressure of oxygen, oh, I forgot to give you the partial pressure of oxygen. The partial pressure of oxygen here, let's say 70 millimeters of mercury. So this is going to be tying in together to form some hypoxemia. So if you were to look at the acid-base status of this patient, you would say that this patient has uncompensated respiratory acidosis with hypoxemia. That's what your diagnosis would be on this acid-base example. And things that can actually result in something like this are things like pneumonias can cause this, things like COPDs can cause this, and even other respiratory disorders can actually result in this. So this is our example 1. If you got example 1 correct, give yourself a pat on the back because you are understanding what I've been teaching you. If you haven't, here's your chance to sign with example number 2. So example number 2, I will now give you other values. So here our pH is 7.5. Our partial pressure of carbon dioxide is 36. Our partial pressure of oxygen is 92. Our bicarb is 27. And our oxygen saturation is 97. Okay? Those are the values. I want you to work out the acid-base status of this patient. You may pause the video right now and work out the answer. I said pause the video. Why are you letting it play? Pause. Okay, so here's the answer. Let's work it out. We'll start again with our pH. Looking at our pH, remember our normal pH is 7.35 to 7.45. So now this 7.5 here is greater than 7.45. So this is greater than our range that is given. So this patient here has an alkalosis. Okay. We now come to our partial pressure of carbon dioxide. Remember that our carbon dioxide partial pressure is going to be 35 millimeters of mercury to about 45 millimeters of mercury. This here 36 is normal. So already this is creating a discongruence between our results, a difference between our results, because here this is normal. So I'll abandon this and I want to put a comment. as of yet because this is normal. So the next thing that I'll do is I'll come to our bicarb. Our bicarb is 27. Remember, our normal is 22 to about 26 milliequivalents. The 27 is greater than this. So it means you're retaining a lot of bicarb in the bloodstream. So because you're retaining a lot of bicarb, this is most likely an alkalosis as well. So as you can see that bicarb is a product of metabolic products. The primary pH of the blood is acidotic. It's not even within the normal range. So already we can tell that here there is no compensation as well, because you'd expect the partial pressure of carbon dioxide here to be quite high. You expect this patient to actually retain a lot of carbon dioxide, but there isn't. So most likely the primary disorder, if we take now our bicarb and you take our pH, most likely this patient has a metabolic, sorry. This patient has a metabolic alkalosis. So most likely this patient has a metabolic alkalosis. Now, let's determine whether there is some compensation or not. If you remember, for metabolic alkalosis, you expect them now to keep a lot of this carbon dioxide in the system, retain it in their system. But they're not, because their carbon dioxide partial pressure is 36. So here there's no compensation. So this is an uncompensated. So this patient here has an uncompensated metabolic alkalosis. We look at our partial pressure of oxygen is 92, which we can say that is slightly or rather our 92 millimeters of mercury, we can say that it's normal. Because it's 80 to 100, and then 97 is normal. So this person has uncompensated metabolic alkalosis and they don't have hypoxia. You can just make a diagnosis here as uncompensated metabolic alkalosis without hypoxemia. So this can be happening in patients that are vomiting, because they are losing a lot of these acids. It can be in those that have NGTs that are running and they're active because they're NGT losses. So to treat these patients, you're going to be giving them, of course, the IV fluids, and this can help in replacing the pH of the bloodstream. Then we'll come now to the very last example. If you have gotten 0 at this point, then please restart the video because you haven't paid attention. So our last example, our pH here is 7.37. Our partial pressure of carbon dioxide is 66 millimeters of mercury. Our partial pressure of oxygen is 70 millimeters of mercury. Our bicarb is 37. And of course, our saturations are 93%. Okay, 93%. So, first thing, we look at our primary defect here. Our primary defect, remember, 7.35 to 7.45. Remember, this person is in the hospital for a reason. They are sick. So this pH is within the normal. So whenever you see this in a sick patient and the pH is normal, it means that this person has probably compensated and most likely has fully compensated. So instead of us using this range here, we're going to compare it to the 7.40. Remember, this is our optimum pH. Remember, 7.3 is much less than the 7.40. So it means that this person here is on the acidic side. So they are on the acidic side of things. We look at the partial pressure of carbon dioxide. Remember, is 35 to about 45. So 66 is much greater than that. So it means that this person is retaining a lot of carbon dioxide. So it means that this person has an acidosis here. Okay, so this acidic is going towards this same acidic, but the pH is within the normal range. So already this partial pressure is acidic, pH is on the acidic side, so most likely that the defect here is of respiratory origin. So this is most likely a respiratory acidosis. Okay. Then we now look at the partial pressure of oxygen, or rather the bicarb, before we come to the partial pressure of oxygen, the bicarb. So the bicarb here, the normal is supposed to be 22 to about 26. But look at this. This person here has a 37. So it means this bicarb level is high. This is normal. because this person is compensating. This acidosis that this respiratory system has created needs to be compensated for by the metabolic system, by this rise in this bicarbonate levels. So this 37 would mean that there is some compensation that is there, because this is going to be pointing towards an alkalosis. So this means that there is some compensation happening. So this is a compensated respiratory alkalosis. Most likely there's a full compensation because it's very close to the normal pH of the body. Remember that it cannot get it to the normal pH, and it cannot cause it to overshoot. So the compensation never causes it to overshoot the pH. It never gets it to the normal optimal pH of the body. Then if we look at now the partial pressure of oxygen is less than 80, so it's less than 80, so there is some hypoxemia. So this is a patient that has a compensated respiratory acidosis with hypoxemia. So that would be your acid-base status of this particular patient. And remember that here there is full compensation because this pH has been brought within the normal range. So most likely this is a patient that has a chronic condition. This is most likely someone with a chronic thing, because the compensation in terms of the renal system usually tends to take some days. How are we going to manage this patient? You manage them with oxygen administration. Remember, when you are giving this oxygen administration, you are not aiming to get the partial pressure of carbon dioxide, to correct this partial pressure of carbon dioxide, because immediately you stop the oxygen in this patient, they'll revert back to whatever they have been having. So most likely this patient has a chronic COPD in this particular example. I really hope you enjoyed this video on acid-base balance, and now you have a better understanding on these ABGs and how to interpret ABGs. If you did like this video, subscribe and hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.